All right, Prof. Rez, you want to introduce?
Oh, yeah. Welcome back, everyone, to another special RR edition of VMR. And I'm not lying, it is RR. It's just a more handsome R is present today. And we got the less handsome one off the screen. I'm very excited to co-discuss, Ravi, with you. How are you doing?
Oh, great, great. I was like going to say RR. I was going to say, how about RVR, rapid ventricular response, courtesy of Human's case. So, but yeah, absolutely stoked to be here. Reza, it's been great. I mean, I remember the first time you showed up at Sinai, 2019, before no, actually 2020, COVID. 2019, I saw you down in DC. Remember that case at was it Diagnosis and Management about the TB, and we thought it was a pelvic malignancy, right? So you remember that. So 2019, 2020, you came here, and then suddenly COVID, when you left, COVID happened and everything shut down. So I was like, man, Reza was the last grand rounds in person. And then actually at the end, when everything opened up, you were the first person back for book club at Sinai. So
Yeah. Dude, I'll never forget that book club, man. You've just been, I just want to put this on record. To have friends like you is really special. And I felt really, yeah, I felt important that day. I felt cared for. I felt wanted. So I appreciate you, and just I'm showing gratitude towards you, Ravi, for creating those platforms for me. Thank you.
oh, welcome. Thank you as well.
We got Hemon, and Hemon always presents great cases from Michigan. And Hemon, I hope you're warm, but I hope your case is fiery. And I hope you give the most challenging parts of the case to Ravi, not Reza. Just remember that, Hemon, so we can stay friends after this session. And I see Prof. Eugene is smiling. Prof. Eugene, you got to change your name to Prof. Eugene. I don't like what I'm seeing up there.
Hello, everybody. I'm Eugene from Ghana. I'll be doing teaching for us today.
Prof. Eugene from Ghana. This is Prof. Rez. All right, Hemon, mic is yours.
Yes, before I start, during my andrology rotation, I had the opportunity to observe many patients with a movement disorder. Although my direct access to individual case was limited, I want to present a meaningful case, so I turned to the literature and came across exception report. I reached out to the author, and I'm very grateful that Dr. Karen Doherty kindly allowed me to present this fascinating case today. So I'm very excited to share this case with our amazing attending Prophet Reza, Dr. Ravi, and I would also like to sincerely thank the patient for generously allowing us to use her video for educational purpose to help care for patients with movement disorder. So I will start. Chief complaint will be a hyperkinetic movement disorder.
Okay, so yeah, we don't have age, we don't have background, but we have this hyperkinetic movement disorder. So what's interesting in the field of neurology, you have certain movement disorders that have various patterns or they have certain frequency, and you could have hypo movement disorders or bradykinetic movement disorders like Parkinsonism, and then you have hyperkinetic movement disorders where there's certain conditions. Robbie recently had mentioned hemiballismus. So these are certain conditions where it could allude you to certain dysfunction within the deeper structures, the subcortical layers of the brain. So movement comes from various centers. You could start exploring your whole neuroanatomical knowledge space and think about cerebellar dysfunction. You could start thinking about certain pathways which go through the basal ganglia. And then when you have a lack of maybe dopamine, maybe you may have hypo kinetic movements, but in this case, hyperkinetic movements are very interesting. There's certain conditions where you have a certain frequency of movement. Is the movement, I want to get more background. Is this movement upon movement? What makes it worse? You have to explore the background of the patient as well. What kind of medications are they on? Some medications can actually or purposely increase the frequency of these movements. Certain meds can cause extrapyramidal symptoms. So there's so much influence from the background that possibly could exist with this case. I have no idea, but I'm sort of thinking about that. And also the past medical history is of importance as well. Certain conditions can be exacerbated, say certain endocrinological conditions could exacerbate certain neurological symptoms, or they could be medical conditions with downstream neurological complications as well. At this point, I wouldn't do a deep dive into diagnosis, but if there was a video, it would be helpful and sort of looking at what the patient is manifesting with, and then also doing a system-wide exploration of the patient to see if there's any downstream effects of this upstream process. What do you think, Prof. Reza, at this point? This is interesting.
I'm not sure if your name is Ravi or Aaron Berkowitz. You remind me so much of Aaron. I have zero to add. That's just beautiful. I'm just very cautious here because this is not a space I feel super comfortable in, Ravi. That's all I have to say.
Okay, Himum, back to you.
Sure. HPI, 22-year-old female present with a 3-year history of action-induced jerk, example, brushing teeth, and tremor when carrying drinks. Urinary copper was elevated twice. Gabapentin was ineffective, and clonazepam initially improved jerks. And months later, she developed fatigue, hypertension, anemia, and peripheral edema. She denied headache, hallucination, preceding infection, toxin exposure, weakness, sensory loss, diplopia, dysarthria, urinary incontinence, tongue biting, fever, weight loss, night sweat, rash, or oral ulcer. Past medical history was none. Medication, she's taking oral contraceptive pill. Family history, no family history of tremor, but her half brother with epilepsy. She's an engineering student. No alcohol, no smoking, and allergies none. I will stop here.
Himon, can you copy and paste that in the chat? I don't know if it seems like the person who's scribing is keeping up with you, but it seems like there's a lot of information that came
She
through.
has yes, she has
She
everything.
had, okay. So, Ravi, this is really interesting. It seems like we got some family history, if I'm not mistaken, Himon, of also movement disorder. This patient is super young, is 22, and has been dealing with this, what seems to be for 3 years, without the extra neurologic manifestations. And so I think, honestly, the best way to approach this case is to have the neurologic issues on one side and then the extra neurologic issues on another side. And depending on who the clinician is, if it's Aaron Berkowitz, he's going to prioritize the neurologic issues. If it's RVR, we're going to prioritize the medical issues. But of course, there's probably going to be an overlap between the two. And so let's start first with talking about the non-neurologic medical issues. And I think, Himon, if I'm not mistaken, it's the anemia, the edema, and the hypertension. Now, when you see anemia in a young woman, presumably without any issues of menstruation, there's a good chance that that anemia will be explained by iron deficiency. So it's going to be very important to have iron studies. And you see, what Ravi and I are doing in this first step is trying to understand how we want to frame the problem, which will really guide our prioritized differential diagnosis. So if we get the iron studies and there isn't iron deficiency, then all of a sudden the cause of anemia becomes something less common than just menstrual blood loss leading to iron deficiency. Now, edema, it's very hard to explain edema in someone who's 22 years old. Think about that for a second. Of course, the severity of edema matters, But as we all age, past the age of 50, the valves in our venous venules become weak and fluid starts accumulating in our legs, but not before the age of 50. So in our problem representation, we have an asterisk by anemia, which will be based on what our studies show, but edema makes its way into our framework. And whenever you have lower extremity edema, it just comes down to, is it the heart, the liver, the kidney, the thyroid? Anytime you say movement disorder and edema, you got to send a TSH. So we're sending the iron studies, we're sending the TSH, but the physical exam, Ravi, is going to be so important, because if we see jugular venous distension, then all of a sudden this edema becomes an issue with the heart, specifically the right side of the heart, which most commonly is injured because of the left side of the heart. So the edema is going to make it there, but I'm open to it for it to be a result of liver, kidney, or cardiac. And the fatigue is not too helpful. The hypertension, that is a bit helpful, because you might ask the question, so why is this patient hypertensive? And hypertension, we all know there's essential hypertension, and for sure it can manifest in the age of 20s, but that's unusual. It's too early. So then all of a sudden I'm starting to put hypertension into that frame, and I'm thinking of secondary causes of hypertension. And if you ask the question in all comers, what's the most common cause of secondary hypertension? It is obstructive sleep apnea. It is someone who is, overweight and has the, metabolic syndrome. Then there's renal artery stenosis, but there's much less common causes like fibromuscular dysplasia. There's endocrinopathies like thyroid disease, PHIOS, etc. So I think the hypertension too has to ultimately be explained. And then I'm going to pass the mic to you, Ravi, to layer in, because to just continue along that neurologic train that you've been going on. But I'll just say this, that with the edema, the hypertension, and maybe even the anemia, all of a sudden I'm wondering if this is beyond a neurologic process and it's something like a substance that has a multi-systemic footprint, as opposed to a primary neurologic disorder that's leading to movement disorder. So as opposed to primary neurologic, something that's secondary, but is also affecting maybe the heart, maybe the hematologic system, etc. But I would love to give the mic to you to layer upon that and maybe incorporate some of the other neurologic features. That's the much more difficult part.
Yeah, this is also a space that is kind of foreign to me, but I'll take a stab at it. But you know what's interesting, Prof. Rez, with this presentation, the age. I mean, this age is ripe for congenital or certain autoimmune, or we have that saying, bad protoplasm, bad substance, bad genes, bad luck. So here we may be dealing with one of those sort of early onset, maybe congenital conditions that manifest at this age, autoimmune. Commonly, this epidemiologically is the age for lupus to rear its head as well. So some autoimmune features along that spectrum could present in this manner. The one thing that's really interesting to layer on your fantastic discussion there, I think with this, it's like you have the edema, you have also this high blood pressure, very odd at this age. So we have to start looking at secondary causes. But this copper issue that Human had mentioned, that it's bold in red and it's really standing out. I'm like, what does that have to do with it? Is Human trying to tempt us there with something that's related to urinary copper? So if you think about copper, usually how is copper in the body manifested? So usually copper will circulate in the blood and it's bound to ceruloplasmin. And that way then it's excreted into the biliary system, right? But urinary copper means that it's not bound to ceruloplasmin, so its free copper is then renally excreted, and now it's ending up in the urine where it shouldn't be. So when you have this kind of dysfunction, is this possibly indicating Wilson's disease, where Wilson's disease may manifest at this age. And we did have a neuro VMR earlier this week of uh, Wilson's disease in a similar patient. So that's something you have to start thinking about. There is also an interesting condition. We have explored the space of copper deficiency. This is more of a copper excess state, but how about copper deficiency? I think we've had recent some VMRs where copper deficiency, say a patient comes with anemia, and they may manifest with iron deficiency anemia. You mentioned anemia as one cause. And I agree with you that menorrhagia and like monthly heavy cycles can, at this age, can result in iron deficiency anemia, which possibly could be the cause here. But when you have anemia, neutropenia, myelopathy, you have to think about copper deficiency, especially if you start having maybe also zinc deficiency as well. You have to start thinking about, and then B12 and all these other things. Like you were mentioning, something in the system, maybe substance, or maybe a deficiency or lack of a substance. Um, Other than that, I don't know. I don't know how to pair up the fatigue is sort of non-specific. Say this patient has iron deficiency anemia, you could say attribute it to that. The high blood pressure is odd. Yeah, is this, are we sort of hinting or hemon hinting at a endocrinological condition here? So you mentioned the circulatory dysfunction with renal vascular or renal artery stenosis or fibromuscular dysplasia. Could this also be an adrenally associated condition? Not sure. And the peripheral edema, I don't know. Is this an albumin issue or is this a hydrostatic pressure issue? I'm not quite sure. But let's get some more aliquots. Anything else? I kind of ranted a bit. I've been rambling there for a bit. Anything got your curiosity, Professor?
No, I love, man. Thanks for tackling I totally forgot about the copper. Thanks for that.
Oh, you're welcome. Back to you, Heman.
Yes, amazing discussion. Kritika, can you share the video for us? Yeah, I would like to show the physical exam the patient had for the tremor and jerk.
Hemon, I know the video is coming up, but the patient is there mentally, right? It's just movement disorder, but nothing, no encephalopathy or, okay.
Just keep your arm up like a
Robbie,
bird's
after
wing,
this done, do you mind if I tackle
and then
this
touch your
one?
nose
Absolutely.
back out to the pen. And try the other hand. Okay, and then just rest, and then bring your fingers in nice and slowly until they're almost touching each other but not quite. Find that tricky?
That Irish accent makes it so much better. Right, Prof.
Okay.
Eugene?
Right. And then draw your spiral.
Kimon, do it. Okay, all right, let me share with you. The reason I wanted to tackle this one was because with Aaron, Robbie, we created a tremors schema. And I think that, and you can see my board right now.
Yes.
And, I want to just first say this. Whenever you're tackling a case where you don't encounter it commonly, and you don't have a great approach, I think just falling back on a basic framework is so helpful, right? Like how we have IMATE for inflammation. For neurology, it's really these 4 buckets. Like, is it a primary neurologic disorder? Is it a metabolic disorder? Is there a structural issue? Or is there toxins or meds? And probably 90% of the time, it's always going to be metabolic toxins or meds, and less commonly these other categories. But up here is where we define tremor. And I'm going to actually ask the audience based on this to label this patient's tremor based on the video. But you have a rest tremor, it's happening at rest. Like there is no, like we saw in the video, she was moving a lot, etc. But it's just happening like that, right? Like Parkinson's. Then you have a postural tremor, which just occurs with posturing. An action tremor, which is like anytime you're just moving, you can have, and you can see that a lot of these overlap, right? Like action tremor, intentional tremor. This one, we saw she definitely had an intentional tremor, right? Like finger to nose, and it was pretty symmetric. And even when she was trying to put these two objects together, and then the action tremor when she was trying to draw that circle. Right, Ravi? I don't know if we really got a rest tremor. I didn't see a rest tremor. So it seems like we're action and intentional, right? And then we come down to our PDX. It's not really rest. We're not worried. Nothing about this sounds Parkinsonian. And we can't, like, even though essential is most common, this is no way. This is too much, you know? It's just the edema, the hypertension, the anemia, how long it's been going on. You have to go beyond essential tremor. So then, where are we? We already talked about a thyroid study, and we're not going to miss it. And Ravi presented a really good case of thyroid disorder. And we talked about copper. I think, you know, the copper study is so hard to interpret. And like, I think for Wilson's, you have to be very cautious. And I always have to go back to the workup of Wilson's. It's not as simple as, oh, the copper is high. The copper may be low, but it's like all stuck in the liver, for example. And there should be other signs, whether it's the heart, the eyes, etc. But we have to, Wilson's is still on the table for sure. Then we have structural cause. And I felt like her tremor was really action and intentional. So I'm really interested in the deep structure of the brain. But the issue with that is like, how do I explain the edema, the hypertension, et cetera? But I would still probably get an MRI, not a CT scan, because you really want to evaluate the cerebellum, and the MRI is better. And then you have, you know, if the rubral area is involved, that can happen with these conditions. Young person, MS, but this would be an odd manifestation of an MS without the other findings that we're all so familiar with in multiple sclerosis. And then you just don't want to miss this stuff. Like, are they withdrawing from alcohol? Is there a substance on board? So where would I go? I think, Ravi, I would say like a TSH, evaluating for Wilson's, and probably an MRI of the brain. And then, of course, a JVP, a BNP, and following that track of edema. Let me leave this up for a second. Do you have anything to add, Ravi, based on this, or?
I think it's wonderful. This really does give us direction. I really appreciate this. And I agree with you. You did just a wonderful job connecting the video to this and just leading us down this framework and the branching point of, I love at the beginning, the definition, the action, as well as the intention. So this I think clears up and gives us direction. And I think those tests that you've ordered will at least help shed some light. If they're negative, we can move through to the next level and then consider some of those more rarer etiologies. Anything else, Prof. Rez? Wonderful walkthrough there. Appreciate it.
Yeah, amazing. Yeah, explanation. That was really great. I will more explain in the physical exam after vitals. Vital temperature was 36.8, heart rate was 78, blood pressure was 150/86, respiratory rate is 14, SpO2 was 99%, and Gen alert and HENT, no JVD, scleroid drugs, no scleroid drugs, no cardiophrasal rings, and a neuro, CN2 and 12 intact, EOMI, no dystonia, rigidity, bradykinesia. So during the video, the postural action tremor of outstretched hand with a stimulus sensitive myoclonus. The tremor was jerky and irregular with a minimal dysmetria, manifest as a slight difficulty with the finger-to-finger testing, and then also the patient showed a tandem difficulty in tandem gait. Reflex was brisk, symmetric, no Babinski sign. Archimedes spiral, difficulty drawing with heavy pen pressure and irregular, but it was a sudden jerky break, not the rhythmic, not like essential tremor is like rhythmic, but this was like more a jerky break. So those all tremor are holding against essential tremor, cerebral disease, and drug toxic metabolic states. So we'll do the more lab result. WBC, initially it was within a normal limit with a mild eosinophil. Months later, she developed a low hemoglobin. Uh, Thyroid function and liver function was within normal limit. BUN was 32.2. Creatine was 2.36. It's elevated. EGFR is 26. ESR 81 elevated. So we rule out the autoimmune vasculitis because of the eosinophil and the elevated ESL. And then thick blood film, there was a no acanthocytis. Neural acanthocytosis is a congenital, so it was ruled out. And copper and the magnesium, and with the elevated, it was normal limit, but with the elevated urinary copper, ceruloplasmin was normal. I will stop here. And then MRI brain scan and EEG was normal. And we even did she did a DOT T scan for the Parkinson. It was normal.
Wonderful case, human. That's really is stretching the limits of my neuro knowledge. But I think it's interesting. Like Reza, you've laid that great foundation with that schema, and I think kind of more. I think I'm a little bit more confident or emboldened to maybe tackle maybe this case here. So I think we're kind of within that space. Yeah, of certain neurological conditions. I think what's interesting here, is this really a tremor? And what really stood out to me, we're thinking maybe is this a tremor of Parkinson's or one of those rhythmic tremors? And what the Hemon has mentioned in a neuro exam is this is jerky. So it's not a, what do you call it, a chorea form, a smooth movement, organized structured movement. It's not a rhythmical movement. It is very disorganized. It is like you have normal sinus rhythm and you have AFib with RVR. Very disorganized. So then when you move away from rhythmic and organized movements, this is not a true tremor. You move into the area of, could this be a myoclonus, which is jerky and disorganized and not rhythmical and so on, like choreiform and so on. So what can cause myoclonus? You start to think about things outside of the neurological systems, like the kidney, and you start thinking about maybe drugs and there's certain things like SSRIs. I don't know about OCPs, substances, and things like that, opioids. And in this case, like, are we dealing with myoclonus here? Are we dealing with a systemic condition? That I don't know, but this has my curiosity. The MRI is normal. We still have this copper issue, and yeah, this at this moment is Wilson still in contention? Not sure, but definitely the BU and creatinine is interesting, right? We just kind of mentioned kidney failure does cause this, what do you call this, toxic metabolic encephalopathy. Although the mental status is good, right? The mental status, she's fine, but that could be a later on effect. I mean, this patient is sort of moving along this journey of whatever condition is causing this. What do you think, Professor, at this point?
I mean, what you just said there is just phenomenal, Ravi. And I think, Hemon, is it true that they were framing it more as myoclonus than tremor? Or is it both tremor and myoclonus?
Yes, tremor and also a myoclonus. I think more emphasis on myoclonus. So
Myo- And then one more question I have for you is that urine albumin is that 3.3 grams per day? That was a spot protein to creatinine ratio.
Yeah, so that's the different range is 300, right? And this is 3,000. It's really huge.
Gotcha. That's really, really helpful. I want to show you guys two incredibly helpful figures. And it might just take me 20 seconds to load them, but you really want to see these because they were created with Aaron Berkowitz. And one of them, let me see, it's all right, so first let me just share with you this screen right here. But before you land on myoclonus, and Ravi, when I have another schema that I made with Aaron. It's not here, but it was a schema on like trying to understand fasciculations. And in that, the DDX was myoclonus, was tremor, was, myochemia, other movement disorders. So I think like actually framing the right disorder is important. There, I think there was definitely a tremor, but there's also myoclonus. So it's like the overlap, and it's easy to see how you can have overlap of these two. They're movement disorders, for goodness sake. But we do have a myoclonus one, and ultimately, it comes down to metabolic, toxic, or meds as the most common. Again, here's our primary neurologic disorder, and just look at this list. None of this would really explain the other findings that we're seeing, the kidneys and everything, right? So then you can eliminate this stuff. Like really, you're here at this sort of renal failure. There wasn't anything structural that we found in the brain. We haven't been told of any medications yet. So what do I do with this? Almost, honestly, what I'm doing, Ravi, is I'm not actually focused on the movement disorder. I'm like, okay, the myoclonus may be secondary to what's happening in the kidneys. Let me draw my attention to the kidneys. And it's not that we just have kidney injury, because kidney injury is so common in systemic diseases, but we have something much more specific, and that is nephrotic syndrome. And so let's talk about nephrotic syndrome. But before, Hema, did you say the albumin was normal in this patient, the serum albumin?
The serum albumin is low.
It's low, less than 3.
Mhm.
Okay. I'm going to share with you guys one more screen since we're sharing a lot here. So now we can say 22 years old, 3 years of movement disorder, and newly diagnosed, I would say, nephrotic syndrome. We have the edema. We have the urine albumin. We're going to give it to her. And we have the serum albumin, right? This triad. And so ultimately, nephrotic syndrome is really a pathologic diagnosis. A lot of times patients with diabetes might have nephrotic range proteinuria, but very rarely have the syndrome. So I wouldn't dismiss this presentation to diabetes, but she doesn't even have diabetes. So then the question becomes, can we make a diagnosis without a kidney biopsy? And the only way you can make the diagnosis without a kidney biopsy is if you're dealing with primary membranous nephropathy, where you can send the phospholipase A2 receptor antibody, and that'll be enough for the diagnosis. But oftentimes, you need the biopsy, you need the electron microscopy, light microscopy, the immunofluorescence to then frame it. And then once you frame it, you got to look for the secondary causes. But I'm going to give the mic to you, Ravi, to speak more on that. But I'm just curious with you, do you feel like it's safe to sort of, I feel like we got to explain nephrotic syndrome. It'll be so odd that she has 2 rare stuff happening. So I'd rather say that the movement stuff is secondary to what's happening in the kidneys and try to explain what's happening in the kidneys.
Absolutely, yeah. I guess exploring or starting with that movement disorder, you're right. What pops up is toxic metabolic encephalopathy and the kidney dysfunction, and the significant urine albumin creatinine ratio is elevated. The only thing is, like with the urine albumin creatinine ratio, you do miss other proteins. Say you start considering paraproteinemias, you need to get the urine protein creatinine ratio in that case. But here we definitely have a low albumin. We're losing albumin, and I think we do have to explore this space. And I remember you have a YouTube video. Don't you have a YouTube video, GN and nephrotic syndrome? A very, very nice lecture on that up on the Clinical Problem Solvers YouTube video. So definitely do look at that as well as this schema. And you have to start considering, I mean, the workup is quite plentiful. And then remember earlier on, we kind of mentioned about lupus. We're in that age range. Do we have to start thinking about GN with lupus? And lupus has that spectrum too, where it could cross over to nephrotic syndrome as well, but more so it stays on that GN side as well. But I think we need data. We definitely need the urinalysis and start doing testing. So HIV, hepatitis, get all those tests, anti-PLA2R, HIV, explore all of those conditions to see, and then ultimately we may end up needing a kidney biopsy. I would do the ANA as well, and also do complement studies. Anything else, Prof. Rez? I think we're definitely on that track right now. We do need to explore why is the kidney affected. And you're right, we're not really in sort of, what do you call it, the uremia range, where you have uremic encephalopathy and movement disorders and asterixis and so on. But it's very intriguing at this point.
Yeah, it's like, I'm wondering, is there like a substance that's infiltrating the kidneys and the brain that is image negative, of course? And that's sort of where I am, because I know there are some substances that can involve both, but what that substance is, I'm not sure.
Yeah, amazing discussion. She mentioned about like the ceruloplasmin may be falsely normal due to oral contraceptive the patient is using it, because the oral contraceptive estrogen increase the hepatic acute phase protein synthesis. So rising ceruloplasmin level and potentially masking Wilson disease. However, the Wilson disease, she mentioned that doesn't have a really nephrotic range problem. So yeah, so I'm going to so the autoimmune, the workup, and the vasculitis, including the SLE, was negative, and HIV, hepatitis, all was negative. And the renal biopsy, I will show it to you. Uh, Okay, so let's see the pathology of a renal biopsy. Kritika, you are doing awesome. Thank you so much. She's been helping to put the video and everything, and she was great help. Kritika, thank you so much.
So, I don't know about you, Prof. Rez, but the last time I looked at histopathology, I don't know. I see them in textbooks, but I definitely need help there. But I guess the hematoxylin eosin stain there, and you see the blue arrow pointing to that space. The space, I guess this looks like a glomerulus, right? So the glomerulus and that whitish area, that space there looks like, I can't really say, it's not infiltrated by cellular material, so it's not an area that's inflamed. There's like almost like a paucity of material there. And then the silver stain, I don't remember was it silver stain is, I don't remember that, but it's pointing to another glomerulus, and it seems rather thickened and exaggerated. So something is happening there. Do you have any idea or any
I do.
knowledge
So
about
I
this?
literally and this is going to be so exciting, Ravi. I took a picture of the screen in GPT 5.2. And I just said nephrotic syndrome. And I took a picture. This is what it said. And we'll see if this is right or wrong. I'm really curious to test this out. This biopsy is classic for membranous nephropathy, a major cause of nephrotic syndrome in adults. You can see on the silver stain, you can see irregular thickening of the glomerular basement membranes with spikes, the yellow arrowhead. These spikes forms between immune complex deposits, the famous spike and dome pattern. on H&E left panel, relatively preserved cellularity. Go Ravi, thickened capillary walls without much hypercellularity. These findings point to membranous nephropathy. Hemon, is that correct?
Well, little bit correct, but
Oh, tell
not
us.
entirely. Okay, so the renal cortex show the FSGS with the yellow and white is globally scolarized granularly and perihilar segmental sclerosis. And then the white, if you see it, there was like partially capillary tuft collapse separating from the basement membrane. This finding is very important also to give us a clue for the what kind of patients renal disease she's having. So yeah, so what would you like to do next?
Yeah, so first of all, GPT failed us, and it doesn't replace a clinician. And it's so interesting. My instinct was there was like that podocytopathy there. But when you have, I mean, it just goes back to the framework that we shared. When you have focal segmental glomerular sclerosis, what does this mean? Sclerosis, scarring. So if you biopsy a bunch of patients with hypertension, for example, they may have some scarring and causing secondary FSGS. Other causes of this scarring can happen, for example, in HIV. Some people can have genetic predispositions to focal segmental glomerular sclerosis. So ultimately, the question becomes, is this primary FSGS or is this secondary? And the only way you can land on primary is you got to rule out the secondary causes. And the secondary causes, it's pretty much I actually have a notebook page on this, Ravi, but I think it involves HIV, and there's probably a long list of infections that we need to send. I don't know if you have your notes up to fill in the gaps, but I'm going to pass the mic to you and then just go on my glass notebook to see what I have there.
Yeah, I think the same thing. You're right. Yeah, what is this indicating? It's indicating scarring. So what kind of popped in my mind was maybe autoimmune conditions. But yeah, HIV is the one that we do always learn about, and I do know COVID could also cause this, but this isn't fitting. This picture isn't fitting COVID. Not fitting, I doubt, but HIV is interesting. I don't know if we got an HIV test because HIV can manifest one of those, what do you call it? It's the great mimickers, right? We have TB, sarcoid, we have leukemias, lymphomas, like these certain conditions that can be great mimickers. So HIV can permeate like everywhere, right? Kidney, as far as the acute infection, it permeates into, and it does have tropism for the brain and starts causing all sorts of conditions, HIV associated dementia, what we call hand. Substances is not, we have seen heroin can cause this as well. So substance use disorder could do it. I don't know about oral contraceptives. That's the only med here. But there is this space of genetic associated FSGS, and that I don't know too much about. And it was the chat was interesting that they mentioned maybe some sort of genetic disorder earlier on. But anything show up in your notes that fits this picture?
Yeah, so thanks. I mean, that's a great DDX. This is what I have on my note page. It says most common idiopathic cause of nephrotic syndrome in adults, aka primary FSGS. And then the secondary causes, we have HIV, which we talked about, reflux nephropathy, healed previous glomerular injury from somewhere else, and massive obesity. Primary versus secondary, it actually has important therapeutic implications. Yeah, so I think, honestly, I think where we need is an HIV test.
Yes, HIV test was negative. Yeah, so the urinary copper, urinary we had increased copper, right? So she thought that it's because of the proteinuria. The copper is always binding with the protein. So when there is a lot of proteinuria, that the urine copper, the copper and the protein binding will come out too. That's why the urinary copper was increased. And also genetic testing was prompt by her young age, myoclonus with a renal failure, and FSGS on biopsy. So the result was showing the SCARB2 mutation, autosomal recessive. It's another progressive myoclonal epilepsy type 4. So the patient went to rapid progression to ESRD. So peritoneal dialysis was necessary, and living donor kidney transplant with the with her mom was given, and it was normalized creatine and resolved nephrotic syndrome.
Wow. I've not heard of this before, but I think the Prof is that in the real world, if you have this case, it's like getting to like who to call for something like this and getting the answer, which was the kidney, and then doing or getting somebody to help with trying to figure out what's going on. It's not something I've seen before.
Gosh, Ravi, I'm right there with you, and I'm so proud of the way we dissected this case because, yeah, we started with like primary neurology. Then we're like, wait, there's other stuff happening. So there's extra neurologic manifestations that have to be explained. Then we rightfully focus on the nephrotic syndrome, but I think we just had difficulty linking that to the movement disorder. And we thought maybe a substance, but once we identified FSGS, just knowing that there is another mutation that also lends itself beyond the kidney to the neurologic manifestations. And so it's like this overlap of myoclonus tremors and primary FSGS. So I just am really grateful for the way we went through that case with the data we have and with the knowledge that we have, and ultimately framed it correctly. And hopefully by inputting that into a chatbot, it should pop out the diagnosis. Do you agree with that, Ravi?
Absolutely, yeah. I definitely appreciate all the input and the learning and direction. You gave such great direction, especially using the frameworks, educating everybody. I think this was a very impactful hour, and I appreciate, yeah, co-discussing and also learning the differences between the tremors and then also exploring the space of kidney and FSGS. Your notes were really, really good, thinking about primary, secondary, and all the different causes. Thank you. Thank you, Heman, for this great case as well. Very well presented.
Thank you for this opportunity. Amazing discussion.
And I guess we'll turn the mic over to Prof. Eugene, our secondary professor, for the great teaching from this case.
Yeah, hello everybody. This is a very fantastic case of a young female 22-year-old with a background of important background, anemia, edema, and hypertension, and also some copper in the urine. Presented with hyperkinetic movement disorder, and then right on the back we were told by Dr. Ravi to explore more of the background, to try to understand what makes it worse, and then also see if this patient is taking any medications that are overlapping or causing this particular movement disorder. Then these 4 clues was what actually guided us to the progress of the case. So Prof. Rez mentioned that when we pick the anemia, for a young person, we can easily rule that one out with possibly menorrhagia causing IDA. But Dr. Ravi added on top that things like copper deficiency, since we're seeing urine copper, also zinc excess, can also lead to anemia. So it's important for us to think outside the box, look for either substance deficiency or substance excess. We also picked the edema and we try to understand that if edema is coupled with a movement disorder, we can consider the thyroid hormone. But we shouldn't forget about the 3 important organs that always cause peripheral edema. That's liver, heart, and kidney. Then we also pick the hypertension, that it's quite odd for a young patient who have hypertension. So it's always important to explore secondary causes. And these secondary causes could be affecting certain organs that may be leading to accumulation of toxins. So if it's happening in the kidneys, like a renal artery stenosis, or we could consider the others just for learning purposes, OSA, fibromuscular dysplasia, pheochromocytoma. Then a bit of pathophysiology with Wilson's. Dr. Ravi mentioned that when you see copper in the urine, usually it's supposed to be excreted through bile, bounded to ceruloplasmin. However, if you're seeing it in urine, it could mean that there could be a defect in the loading of copper. So when there's a genetic defect, in Wilson's example, you may not load copper properly to ceruloplasmin, and so you have spillage into blood, and then you can find it in urine. Then we had to now explore what kind of movement disorder is this, and the video was very important. Initially, we were thinking it's a tremor, but then we came back to organize our thoughts that it's probably an overlap between a tremor and myoclonus. And when you have either tremor or myoclonus, it's important to look at the schema, whether it's from a primary neurologic cause, or either metabolic, or from a toxin or structural. So from the primary neurologic causes, we were not really seeing anything that can affect a person at that young age. And the movement disorder was rather suggestive of, was not intentional. It was more of like action, and then also more of like one suggestive of either structural or metabolic or toxins. And so we had to do imaging. Imaging was negative. So we now went on to look at the method. And so from the labs actually gave us another clearer side of this case, whereby we saw the elevated urine proteinuria, so nephrotic urine proteinuria, and then low albumin. And then we thought, okay, could this be nephrotic syndrome? And then we pulled out a scheme of nephrotic syndrome, whereby we understood that in nephrotic syndrome, you could have also losses of important proteins, and you could also have losses of copper as well. So that could explain the urine copper that we were seeing. And then to tie it to this case, we needed to because nephrotic syndrome in a young patient, you need to find the cause. In fact, any nephrotic syndrome at all, you need to find the cause. So you need to biopsy the kidney. And so we did a biopsy and we got FSGS. And you need to understand that you have to, FSGS might be either primary or secondary. So the secondary causes either from HIV, or Dr. Ravi mentioned, either COVID or massive obesity. So we did HIV, was negative, and then we targeted on primary. Primary means you need to do some genetic testing. We did a genetic testing, and it came out that the gene that was causing this particular FSGS was also implicated in the epileptiform movements that we're seeing in this patient. So a very fantastic case, brought us a lot of learning from movement disorder to metabolic causes to anemia in a young patient, edema, hypertension, and then finally FSGS, primary FSGS. Yeah, so that's where I'll put my teaching points.
Prof. Eugene, that was spectacular, man. It was awesome to watch you go through that journey. And I just want to say, if you guys go back to the beginning of the recording, Ravi right away said, look, the age is young and I'm worried about something genetic. And so, Ravi, I think your instinct was really spot on there, man. And it's like a great reminder and a great teaching moment. Like when you have a young patient, to really think about genetic syndromes that the majority we're not familiar with, but exist out there for us to research and discover.
Yeah, thank you, Professor, for coming on and co-discussing. I know it's early for you. It's like 9 a.m. and you're probably getting ready for rounds, but looking forward to doing this again, hopefully. And thank you, Prof. Eugene. Wonderful, wonderful teaching points. All right, have a great weekend, and hope everybody as well. Take care. Bye.